Childbirth is surrounded by deeply rooted beliefs, cultural narratives, and personal opinions that are often passed from one generation to another. While shared experiences can be valuable, many commonly held ideas about vaginal birth, often referred to as normal delivery, and cesarean section are not supported by medical evidence. These myths can create unnecessary fear, guilt, or unrealistic expectations for pregnant women and their families. A clear, medically grounded understanding of these misconceptions is essential for informed decision-making and emotional well-being throughout pregnancy and childbirth. One of the most widespread myths is that vaginal birth is always safer than cesarean section. While vaginal delivery is generally associated with fewer complications in low-risk pregnancies, it is not universally safer in all situations. Medical safety depends on the specific circumstances of the mother and baby. Conditions such as placenta previa, severe preeclampsia, fetal distress, or obstructed labor make cesarean section the safer and sometimes the only viable option. In these cases, attempting vaginal birth can increase the risk of severe hemorrhage, uterine rupture, brain injury, or death. Modern obstetrics recognizes cesarean section as a life-saving procedure when medically indicated, not a failure of natural birth. Another common myth is that cesarean section is an easy or painless way to give birth. This misconception often arises because cesarean delivery avoids labor pain. However, cesarean section is major abdominal surgery with significant physical demands during recovery. While pain during the operation is controlled through anesthesia, postoperative pain can be substantial and prolonged. Women recovering from cesarean delivery must heal from incisions in both the abdominal wall and uterus, manage mobility limitations, and face higher risks of infection and blood clots. The absence of labor pain does not equate to an easier overall birth experience. Many people believe that once a woman has a cesarean section, she can never have a vaginal birth in future pregnancies. This belief, often summarized as once a cesarean, always a cesarean, is outdated. Vaginal birth after cesarean, commonly known as VBAC, is a medically supported option for many women, depending on the type of uterine incision, the reason for the previous cesarean, and the presence of appropriate medical facilities. While VBAC carries a small risk of uterine rupture, for carefully selected candidates it can be a safe and beneficial alternative to repeat cesarean surgery. Blanket statements that rule out vaginal birth after cesarean ignore individual risk assessment and modern clinical guidelines. Another pervasive myth is that women who deliver by cesarean section are weak or did not try hard enough. This belief is harmful and has no scientific basis. Labor and delivery outcomes are influenced by factors beyond a woman's control, including pelvic anatomy, fetal size and position, placental function, and unpredictable labor complications. Strength, endurance, and pain tolerance do not determine whether a woman will require surgical delivery. In many cases, choosing or accepting a cesarean section reflects strength, responsibility, and commitment to the safety of both mother and child, not weakness. There is also a common belief that vaginal birth always results in severe tearing and long-term pelvic damage. While perineal tears can occur, especially in first-time births, most are minor and heal well with proper care. Severe tears involving the anal sphincter are relatively uncommon and are often associated with specific risk factors such as large babies, prolonged labor, or instrumental delivery. Moreover, pelvic floor health is influenced by multiple factors including genetics, age, body weight, and number of pregnancies, not vaginal birth alone. With appropriate prenatal exercises, controlled pushing techniques, and skilled obstetric care, many women recover fully after vaginal delivery without lasting pelvic floor dysfunction. Conversely, some believe that cesarean section completely protects women from pelvic floor problems. While cesarean delivery may reduce the risk of certain pelvic floor injuries, it does not eliminate them entirely. Pregnancy itself places stress on the pelvic floor due to hormonal changes and increased uterine weight. Additionally, cesarean section introduces other long-term risks, including chronic pelvic pain, surgical adhesions, and complications in future pregnancies. Presenting cesarean delivery as a risk-free alternative misrepresents the medical reality. Another myth is that labor pain is unbearable and impossible to manage without surgery. Labor pain is intense, but it varies widely among women and is influenced by physical, emotional, and environmental factors. Modern obstetrics offers a range of pain management options, including epidural anesthesia, spinal analgesia, and non-pharmacological methods such as breathing techniques, movement, water therapy, and continuous labor support. Many women successfully manage labor pain and describe it as purposeful and manageable when adequately supported. Fear-based narratives often exaggerate pain and discourage women from considering vaginal birth even when it is medically appropriate. Some people believe that cesarean section is safer for the baby in all cases. While cesarean delivery can be life-saving in specific situations, it is not universally safer for newborns. Babies born by planned cesarean section have higher rates of transient breathing difficulties due to delayed clearance of lung fluid. They may also experience challenges with early breastfeeding initiation. When there is no medical indication, routine cesarean delivery does not improve neonatal outcomes compared to vaginal birth and may introduce avoidable risks. A related myth is that induction of labor always leads to cesarean section. While induction does increase the likelihood of interventions, especially in first-time mothers with an unfavorable cervix, it does not inevitably result in surgical delivery. When properly indicated and managed, many inductions result in successful vaginal births. The key factors include cervical readiness, appropriate use of medications, and patience during labor progression. The belief that induction automatically equals cesarean can create unnecessary fear and resistance to medically necessary interventions. There is also a misconception that planned birth preferences guarantee outcomes. Some women believe that preparing extensively for vaginal birth ensures they will avoid cesarean delivery. While education and preparation are valuable, childbirth remains unpredictable. Complications can arise suddenly even in healthy pregnancies. Viewing cesarean delivery as a failure can increase emotional distress when plans change. A more balanced understanding recognizes that flexibility and safety are central to positive birth experiences. Finally, a common myth is that the mode of delivery defines a woman's success as a mother. This belief places undue emotional pressure on women and ignores the complexity of childbirth. Successful childbirth is defined by the health and well-being of both mother and baby, not by the method of delivery. Whether a baby is born vaginally or through cesarean section, the act of carrying a pregnancy and bringing a child into the world reflects profound physical and emotional strength. Myths surrounding normal delivery and cesarean section often distort reality and influence decisions based on fear rather than facts. Vaginal birth and cesarean delivery are both valid medical pathways, each with specific benefits, risks, and appropriate indications. Dispelling these misconceptions allows women to approach childbirth with realistic expectations, informed consent, and confidence in medical guidance. Accurate knowledge empowers women to focus on what truly matters: safe delivery, healthy recovery, and the well-being of their child.